It is now noon Central Standard Time in Wisconsin. We'll start the presentation. Today, we are so fortunate to have the presentation on Shockwave and the case studies involved with the information. So thank you for joining us today, Dr. McAlister and Dr. Wijting. We appreciate you. The next slide will also be a very much heartfelt thanks to Zimmer MedizinSystems for being our corporate partner today and sponsoring this fabulous event. Okay, everybody can read continuing education requirements for Wisconsin is just this, so thank you. That concludes my piece of the puzzle. Regina and Gerald are representatives of Zimmer MedizinSystems, and they will take over the rest of the presentation. Thank you all for being here today. Bye-bye.
Thank you, Leah.
Thank you.
Very happy to be here. Hello and welcome to today's webinar, Shockwave Therapy and High Energy Inductive Therapy. I'm Regina West, and I'll be moderating the webinar today. During the presentations, feel free to submit questions in the chat box. Our speakers will answer your questions live during the Q&A segments following their presentations. If there's not enough time remaining to get to every question, we will email answers to you after the webinar at some point. Now I'd like to introduce the speakers a little bit more formally here. For today's webinar, we have Dr. Davis McAlister, who will be speaking during our first hour on the benefits of extracorporeal shockwave therapy in muscular injury recovery. Hello, Dr. McAlister. Hello again.
Hello. Thank you for having me.
Of course. Thank you for being here. And we also have Dr. Yorick Wijting. Hi, Dr. Wijting. He's standing by. Hi. He'll be speaking during our second hour on high energy inductive therapy, a review, case studies, and treatment strategies. Also, we have Gerald Gable, who is the Vice President of Sales for the Physical Medicine Division of Zimmer MedizinSystems, and he'll be doing a couple small presentations as well later on. So thank you everyone for being here. And now I'd like to briefly give some background on Dr. McAlister, who will be speaking in just a moment on shockwave therapy. Dr. Davis McAlister is an author, public speaker, veteran, coach, and doctor of chiropractic. He specializes in sports chiropractic and is a certified strength and conditioning coach. Dr. McAlister is a clinical faculty doctor at Parker University Chiropractic Clinic in Dallas. He provides valuable instruction to doctors, trainers, and strength and conditioning coaches. He also works with high-performance athletes and coaches powerlifting, and he coaches powerlifting, excuse me. With over 20 years of diverse experience, he's taught and coached in Texas at the high school and university levels, and he's also served in the U.S. Army for 8 years before earning a Bachelor of Science from Mississippi State University. He was awarded a Master of Educational Leadership from Sul-Ross State University and a Bachelor of Anatomy, a Doctor of Chiropractic, and a Master of Strength and Performance, all from Parker University. And now we'll get to his presentation very shortly, but just a bit about Dr. Wijting, who will be speaking in our second hour on high energy inductive therapy. Just a little tidbit on him first. Originally from Netherlands, Dr. Yorick Wijting received his physical therapy training at Rotterdam University of Applied Sciences. He left the Netherlands to work in Paris, Switzerland, Germany, and South Africa, where he also taught before moving to the US in 1996. Once here, he earned his DPT degree at University of St. Augustine for Health Sciences in Florida. He later oversaw a staff of 120 with responsibilities in inpatient rehab, outpatient, and skilled nursing. His focus on administration and new program development shifted to continuing education, mostly in orthopedics and therapeutic modalities. Later, as a senior director of global education at DJO Global in San Diego, Dr. Wijting devoted his energies to the continuing education circuit nationwide and internationally. Today, he operates his Gilroy, California private practice, specialist physical therapy, and continues teaching. His practice uses advanced equipment to enhance rehabilitation efforts. And we'll share a bit more about Dr. Wijting's experience and background when we bring him back for his presentation in the second hour. But for now, with no further wait, I'll hand it over to you, Dr. McAlister, for the first presentation.
Thank you.
Thank you.
I want to thank everybody for coming on and listening to us, not only for 1, but 2 hours. You only have to listen to me for an hour. But we're going to talk about the benefits of extracorporeal shockwave therapy as it relates to muscular injury recovery. And I know everybody's got different scopes of practice within their states. I know down here in the state of Texas, we have to kind of restrict everything more to an MSK type therapy. And in some aspects, some neuro involved, but primarily MSK. So what I want to do today is I want to make sure that we have an understanding of what extracorporeal shockwave therapy is, and then how it's going to benefit your patients for MSK recovery. So shockwaves themselves are a high energy acoustic wave, and it's generated outside the body and transmitted obviously through the skin and into the underlying tissues in the targeted area. So there's a lot of history that goes along with this, and I'll talk a little bit about the history as we go through this. But extracorporeal shockwave therapy is considered non-invasive, and it uses high energy shockwaves to help stimulate healing. And we're going to talk about the different things that it stimulates as we go through this webinar today. But it uses those shockwaves from a point surface and are focused into a specific area. And then as far as focal, there's different types. We're going to talk about the couple different types as well. And these shockwaves are high energy and can penetrate deep down into the tissue to be able to treat deeper injuries like tendinopathies. And we'll get into the different things that it has been FDA approved for here in the United States. So that we understand the difference. So focused, it's going to be a focal point at the highest energy where the shockwave penetrates deep down into the tissue. And it's meant initially, when the first designs came out, it was initially designed for a destructive effect, such as in lithotripsy, breaking up kidney stones. And then radial came along, and what it does is it starts at a focal point and it diffuses out into the tissue into a broader treatment area, and it's going to make it effective for treating deeper injuries like tendinopathies. And this is due to the evolution of the different types of applicator designs that are used to be able to administer treatment and take it from a negative effect to a therapeutic effect that's going to be more conducive to your MSK type conditions. So we just have a little diagram here that shows the difference. And we have our focus, so it's a broader transmitter applicator, and then it's meant to penetrate deep down into a single focused area versus your radial. Radial starts with a smaller area and then broadcasts out or radiates out, so to speak, and affects more of the surrounding tissue as well as the affected area. So just a little bit of a comparison here. Between radial versus focused. We've talked about the wave types, energy distribution. On the radial side, you have high energy at the surface that gradually diffuses out, and it's great for functional tissue zones. And the thing is with focus is it very high energy at depth, but it requires exact targeting. So you got to make sure you're very precise on where you're sending those waves down into the tissue. Penetration overall, you have 4 to 5 centimeters, which is pretty deep. You can still get down into the deepest part of the tissues all the way down to the bone with that depth. And then you have things like, with the focus, it's up to 12 centimeters, depending on the settings that you use. Most common uses for radial, at least, where I'm at, the most common things that we use it for is plantar fasciitis, tennis elbow, myofascial pain, muscle tears. I've used it for a lot of muscle tears, especially with hamstring injuries. And we'll go through that a little bit in a case study. But with the focus, you're going to look at deeper structures, and you can use it for calcific tendinopathy and bone pathologies. So pain level on the radial side is generally well tolerated. The focus can be a little bit more impactful as far as the patient's concerned and create a great deal of discomfort, and especially if you don't use any anesthesia that goes with it. Again, the treatment area is more of a large functional zone, especially if you have athletes. It's really great for athlete recovery. And then you have your narrow target area related to the focus. Learning curve, for me, the radial is extremely easy to learn. It was really easy to integrate and very quickly implemented into practice. Whereas versus the focus requires a little bit more precise imaging. You've got to be really targeted as far as where you're aiming that treatment area and the shock waves to get down to that point. Cost effectiveness, the radial tends to be a lot more affordable and it's widely available. And then with the focus, a lot of the devices that are out there are much higher cost. They're extremely expensive. And a lot of them are limited to more specialty type centers. I know that there are some individual offices that have purchased focused, or a couple of them that I've talked to, when we got to actually looking at their designs, they were kind of actually knockoff designs. So you have to be very, very careful about who and what you're buying. Example systems though are, under the radial, you have your Zimmer Impulse Pro, which is what I actually use. And then on the focus side, you have the PiezoWave. Okay, so just a little bit of history. I'm going to run through this briefly because this presentation initially was designed for a 2-hour presentation. So I'm going to move through these fairly quickly. Shockwaves started kind of being explored first, more along the lines of underwater explosive research during World War II. And it was based on its ability to be able to use sonic waves to be able to break things apart. It was even found that there was technology that was being developed towards the end of World War II that was using shockwaves to be able to incapacitate enemy soldiers. And so that's where a lot of the experimentation with that started to come in. Then you get to the early 1980s, and it became first used in Europe, and they started doing studies on the use of shockwaves for kidney stones. And one of the things that they did notice is that patients were seeming to get relief in other areas, and to a certain degree had some improvement in range of motion around the treated area. So that started leading to more research around MSK disorders. We get to the 1990s, and you start getting the first published studies for extracorporeal shockwave therapy for MSK conditions. So they started doing studies on plantar fasciitis, tennis elbow, calcific tendonitis. When you hit 97, this is the first studies of plantar fasciitis that start being widely published. Then you have the radial concept that's produced in the early 2000s. In the year 2000, you got FDA approval for your chronic plantar fasciitis, and then 2002, it bumped out to your tennis elbow or lateral epicondylitis. 2004, you got non-union fractures. Now, depending on the state that you're in, I could tell you that in our state, we're not allowed to treat fractures. But if the scope of practice in your state allows you to do that, then it's very effective for being able to treat non-union fractures. As far as and then 2005, you have FDA clearance in the U.S. for most of the MSK conditions. You have FDA approval in 2008 for calcific tendonitis. 2010s, we start getting more widespread clinical adoption. So you have more sports medicine clinics, rehab clinics, chiropractic. They're really starting to integrate extracorporeal shockwave therapy into their practices and rehab protocols. And then starting in 2020, you have research just started exploding. There's a lot more meta-analyses that are being published in RCTs, to help validate that, this type of therapy in muscle tears is really effective. And also for Achilles tendinopathy, myofascial pain. And the overall future outlook for this is that you're going to have possibilities of neural regeneration because of the cell proliferation aspects of the treatment. And then you have scar remodeling, fascia health. So there's a lot of ongoing trials and things like that, especially in the areas where they're looking at treating neuropathies and chronic pain type syndromes. I put this in here. This is one of the original designs for the focused shockwave therapy, one of the first ones that was designed back in the early 80s, used to treat. And I want you to keep this in mind as I move on to the next slides so that we can kind of talk about what some of the pros and cons of this were. So some of the drawbacks to these, you had to have a nerve block in order to be able to do the treatment or some type of anesthesia. Usually the treatment time was about 30 minutes and it was extremely painful, thus the need for nerve blocks or anesthesia. And then there was a considerable amount of downtime for the patient after they got treated. Also from a scheduling standpoint and from having availability in an office. You had to have a special room because of the size of the device that was first implemented. And then scheduling problems because it's a 30-minute time frame. Then you have to have the prep time to administer the neural blocks or anesthesia. So it really was not very conducive for a good patient flow. Now, with the radial type, it can be temporarily painful during treatment. You have skin irritation or bruising that can happen, and I will emphasize you have to pay attention to the area that you are doing treatment in. If you're in relatively bony areas, you do have to be conscious of that. And there are some applicator covers, depending on the design that you use, that can help with buffering that. It may not be as effective on some MSK conditions, but those are things that we can have a discussion about later on. And then typically it's not going to be covered by insurance. However, I have recently learned that there's a couple of states that have basically a state supplemental insurance that it's in addition to Medicare or Medicaid, and they have been providing reimbursement for MSK extracorporeal shockwave therapy treatment. So that may be a possibility. So you may want to look into the background of your state and see what they offer. Advantages for radial is it's non-invasive. There's no anesthesia that's required. Very short treatment time. Everything's based on the number of pulses that you use, not based on time. There's minimal downtime depending on the diagnosis. Usually, I can tell you that everybody that I've treated with it, I have not had them get up off the table and say that they were worse. I've had some that say, yeah, I noticed a little bit of difference. And then after the success of treatment sessions that we have with it, they start noticing significant improvement. But I have not had anybody that it's caused them to have downtime as of yet. But we do have to put that out there that there is a possibility for that. And then potential long-term benefits, with fewer side effects associated with it. So overall, how it works. So you've got a projectile inside an electromagnetic coil. Now there's different designs. The original designs for the focused, and even still some of the other modern designs, they use an air compressor. So it's going to have an air compressor that's going to drive a piston inside of an applicator and then strikes the head of the applicator. This design that I like is it uses an electromagnetic coil and it rapidly accelerates that piston and it helps control it a little more. This also is going to generate kinetic energy that's transferred to the tissue in the form of a pressure wave. So a little bit of physics behind this, if we wanted to give somebody some PTS from having to study physics in undergrad. But it uses a nonlinear high pressure acoustic wave. So your pressure wave is going to rise rapidly and then have a short duration, and it's going to be followed by a low pressure phase. So it's going to travel faster than sound and tissue, and it's going to trigger mechanical and cellular responses versus your different types of ultrasound. Your traditional ultrasound is more of a sinusoidal wave. We talked about the sine waves, cosine. Again, initiate some PTS from having to study trigonometry and geometry as well. But you can see the difference in the wave patterns, and it's very, very controlled. So the drive system, you're going to have a peak energy that's achieved slower in your air compressed. All right, and it's going to drive it up, and then all of a sudden it drops off. Versus the impulse is going to allow you to be able to do a more gradual rise, and then you have your downslope there. So the positives to that is that it's going to require less maintenance, than the air compressed versions. You're going to have a lot more durability. It's more comfortable, and it's going to be a lot more cost effective because you're not having to replace parts so often. Now, as far as overall how it affects the tissue, so you have 4 different effects that we talk about here. You have cavitation, mechanical transduction, neovascularization, and then pain modulation. So, with cavitation, you're going to have some microbubbles that are going to form. They're going to collapse in the fluid, and it creates a shear force that's going to help trigger repair within the tissues. Your mechanotransduction, so you have cellular deformation, which is going to initiate gene signaling to be able to start producing proteins for healing. You've got neovascularization, which is going to be new blood vessel formation. It's going to help improve your tissue perfusion. It's going to be able to take a lot of that swelling out and be able to allow more healing and more white blood cells and all those things that need to get in there to be able to help the tissue heal. And then your pain modulation is going to decrease your substance P, and it's going to desensitize those C fibers and reduce your neurogenic inflammation around the site of injury. Now, why does this matter? So what you're doing is you're taking physical energy, you're creating a biological response that's going to turn into tissue healing. So what it does, it helps jumpstart stalled healing, especially if you have a chronic condition. I've had really, really good success with a lot of chronic conditions, things that have just been nagging, been there for a long while. We're able to get in there and be able to stimulate some healing and get a really good response out of that. So unlike medication or a lot of passive therapies, this is going to activate your body's repair systems inside. And the type of applicator, the frequency that you use, and the energy level that you set it at is going to matter for the different outcomes that you're looking for. So overall, the therapeutic effect, so initially you are kind of creating an initial micro trauma or slight inflammatory response because you are stimulating that area, but it's drawing attention to that area. You're going to have some pain reduction that we talked about, starting increasing the blood flow, getting that neovascularization in there. And then what that results then is turning into an anti-inflammatory type effect. The tissue is going to start to regenerate. The muscle eventually is going to finally relax, and you're going to get improved mobility and function out of that. So some of the indications or different conditions, you have tendinopathies, you have plantar fasciitis that we talked about on the history timeline, your calcific tendinitis, myofascial pain syndrome, and then your non-healing fractures, depending on your scope of practice. Also, there have been some studies done. It started off in Germany and Europe on erectile dysfunction, and I found out recently that there are people that are offering it for that type of service here in the United States. I do not do that personally. It's not something that I want to get into, but if that's your thing, then you can look into that. So some different side effects that you can consider: you have mild to moderate discomfort. Initially, sometimes it can cause a little bit of bruising, but again, I've not had anybody ever get worse as a result of it. A little bit of bruising and swelling, possibly at the treatment site, skin redness and irritation. On the downside, because we do have to talk about what all the possibilities are. You are sending little micro traumas into an area. It could cause a little bit of numbness, tingling. Some people, it could cause a headache, depending on the type of toxin release that you got, and located where you did the treatment at. And hopefully you're not doing it on their head. But you have rare cases of more serious side effects, such as tissue damage, nerve injury, or blood clots. And again, you've got to pay attention to your population that you're dealing with, your age ranges. When we first got these units down here in Dallas, we had a doctor that came up. He's a little bit on up there in years. And of course, you have that thinning of the skin. And he walked up and just grabbed it and put it on his arm and turned it on, didn't pay attention to the settings, and actually tore his skin a little bit. And so you do have to be careful about those things and pay attention to that. So red flags and contraindications. Pregnancy, we put that on there as general, but it's mainly around the torso area. If you're on the distal aspect of your extremities, that's obviously going to be safe. You just don't want to do it around anywhere at the torso area where the baby is. Blood clotting disorders, it will dislodge blood clots. So you can have to be careful with DVTs, especially open wounds and skin infections. You don't want to traumatize that. And because of the cell proliferation, we don't want to stimulate cell proliferation on areas where you have cancer and tumors. Some nerve and vascular disorders, and again, they are doing studies on peripheral neuropathy, but as of right now, if they have that, they're telling you not to do it. And we'll go through a case study example as to why that is. If they have DVTs, Raynaud's disease, obviously you're seeing kind of a pattern here on decreased blood flow or neurological issues on the distal extremities. And so I took these up and then I broke them up into a red light, yellow light, and green light type categories. So on your absolute contraindications, you've got your DVTs and your clotting disorders, especially near the treatment site. You're going to have open wounds, infections, or skin ulcerations. You don't want to do it over those sites. We talked about cancer already. And then we also talked about pregnancy. Avoid treating the abdomen or lumbar spine in particular. Some yellow lights, some things that you need to consider. If they've had a recent surgery or fracture within the last 6 to 8 weeks, you want to make sure that you're cooperating and co-managing to make sure that they're cleared before you start doing that type of treatment, especially after surgery. peripheral neuropathy, especially if they've got significantly reduced sensation, you're not going to get any feedback and the patient's not going to be able to feel anything. So you could actually do more harm than good if you're treating in that area and you can't get any feedback from the patient. You don't want to do it over metal implants. It can cause reflective waves. It can also cause pain, generate excessive heat. So you don't want to do that. You have thin skin over bone, which I've already talked about, with a doc that, tore the skin because he had very, very thin skin and didn't put an applicator cover over the top of it. You have patients with very low pain threshold or anxiety, itself. So you may have to kind of coach your patients through that. But you're absolutely safe for your chronic tendon and muscle injuries, your myofascial trigger points, plantar fasciitis, lateral epicondylitis, tennis elbow that we talked about. You have your hamstring strains. I've done a lot of hamstring strains. And then your return to play rehab for your athletes. So we talked about, some of these contraindications, a case vignette that we had here, and this was a real patient example. So we had a 63-year-old diabetic male who did have a significant peripheral neuropathy. And, he underwent some radial extracorporeal shockwave therapy for plantar fasciitis without any prior sensory screening. They had not done any neuro screening, no microfilament, no sharp, soft type sensation. And so as a result of that, he ended up experiencing some significant tissue damage, had some blistering in the area, and due to a lack of pain, and actually put him down for several weeks having to recover from that because obviously he's getting older. He's got some neuropathy, so that slows tissue healing down, and it ended up creating some blisters that took longer to heal. So the treatment was stopped and wound care was given, but even though it's considered low risk, if they have severe diabetic peripheral neuropathy, there's a lack of sensation that we talked about, and it makes standard dosages unsafe. So just doing something simple like, a nerve test, a microfilament test, vibration test, sharp, soft, any of those things would have been a whole lot more beneficial and would have been able to save this patient and the doctor the anxiety and stress that came along with this incident. So some key parameters when we're talking about radial shockwave therapy, you need to consider the energy levels. We put them in categories of millijoules. You'll see some studies that they have a modulation or different types of units that they do. They'll do them on, especially with focus, they'll do millijoules per millimeter squared. We keep everything simple. So we would just put ours in millijoules, and then the energy delivered is basically the energy delivered per shock. I tend to use the word pulse, especially when I'm dealing with patients instead of shocks, but that's essentially what we're dealing with. Your low energy is considered less than 80 millijoules, and it's used for a lot of your superficial type conditions, while your high energy, which is more than 120, is used for your deeper tissues. Frequency, again, this is the number of shocks or pulses per second that are delivered, and your treatment is going to be based on those number of pulses that you're given. Your frequency is somewhere usually between 5 and 10 hertz, depending on the condition that you're treating. And then the number of shocks per session is going to range anywhere from 1,500 up to 3,000 per session. Let's get into a few little case studies here. So I only put this on here just as a reference. This is the device that I specifically use. So when I'm talking about these case studies, this is the instrument that I was using to be able to deliver treatment. And in our first one, I have a case study of a 20-year-old male. He was called and referred to me by his dad. I knew his dad. His dad called and said, "Hey, my son got injured. He was out on a single play. He was a receiver, got rolled up, ended up hurting his AC joint on his right shoulder, ended up with a right torn hamstring, and it was evident that it was torn because he had blood pooling and the whole 9 yards, and then a left strained hamstring. So we had both hamstrings that we were having to deal with, obviously one worse than the other. He had significant pain. He was 8 out of 10 on average, and obviously 10 out of 10. When he first came in, he was on crutches. He couldn't even walk. He was having a hard time even dressing himself. So obviously, he couldn't run. Lifting weights was out of the question. And so his quality of life just in general was being affected, but it was also keeping him from being able to get back out on the field and play. So this is 2 weeks after the fact. So after he had the injury, they had been putting him through some physical therapy with the trainers at the program, and just were not seeing the results. And but essentially what they were looking at, he was looking at basically being done for the rest of that season. And so you can see the blood that's pooling and transitioning across the knee. The actual injury was up in the mid thigh, where you can see a lot of that darkness. You can see where the blood was finally just perfusing across the joint space there into the lower leg. But we did get it confirmed with a diagnostic ultrasound, and you could see the tear, the dark segments in there, the tears that are in the muscle, the most significant being over there on that left-hand side. So I did a little bit of research. This was my first case actually that I got to treat doing this. And so I went back and started doing a little bit of research. I made some phone calls and asked for other people that had some experience with this, and obviously to the people that have been doing research and developing these devices and trying to get input on what the best approach was going to be. And I had a couple different studies that I found. There was one back in 2013 where they had patients that showed great improvements in pain and function compared to those that had a sham treatment for a hamstring muscle strain. And they would do 3 treatment sessions, around 2,000 shocks per session, delivered at about 8 hertz at an energy level of 80 millijoules. So those are the things that we were looking at. I was looking at and comparing, so you have the other one down there that they were doing frequency of 10 hertz and an energy level of 160. And then the last one down there, there's obviously a range that they were doing. They were treating at different levels to see what the effect was. And so when we look at that, we try to figure out what's the median that we can fall into, but also given this patient, he's trying to get back to play. So he managed to get put on home study for a couple weeks. They gave me a couple weeks to work with him and try to get him back so we could get him back to play. So a summary of all the research we did. So we showed about 60 to 90% success rate, depending on the severity of the injury. And he had a pretty severe injury. So, we're going to go based off of pain reduction, functional outcomes, and then the overall patient satisfaction as far as, how we're going to judge the response for this patient to care. So we set up our protocol. We're going to do 3 to 4 sessions per week. We ended up getting an extra week out of it. Initially, we were only told we were going to get 2 weeks. We did get 3 weeks out of that before we had to send him back. So it's not a long time to try to turn a hamstring injury. Usually a hamstring injury of that severity, you're looking at 12 to 16 weeks recovery, trying to get them back. We're already 2 weeks in by this point. So we're looking at about 2,000 pulses per session, frequency at 10 that we set. And then your energy levels, we gradually increased the energy levels as we went. Then we were also incorporating some isometrics and some PNF stretching on the antagonistic muscle groups, trying to get stress off of that hamstring so that it had time to be able to adequately recover. Overall prognosis. So in week 1, by the time we got to the end of week 1, we ended up treating again, 3 to 4 times a week. It was a lot more intensive. Traditionally, this is not how we're going to typically do it. We're going to usually just treat them once a week or so, maybe twice a week at the most. But obviously, we were trying to get this guy turned around very quickly. So we went a lot more aggressive with it. By the end of the first week, pain level had dropped down to 3 out of 10. He was able to be ambulatory, did not have to have the crutches anymore, was able to semi-walk normal. ADLs were improved, so he was able to stand unassisted, was able to start walking without assistance, dressing himself like he wanted to. So that was a huge improvement for us to be able to see that. And then at the end of week 2, we were down to a 1 out of 10, and we were able to perform isometrics independently, and he was actually able to start jogging, doing some light jogging by this point. So to go from being on crutches and not being able to ambulate on his own without crutches to being able to do a light jog within 2 weeks, and we're talking about 4 weeks post-injury, that's pretty good. And then by the end of the 3rd week, we were down to 0 pain. We were able to start getting into those fibrous tissues a little more, breaking up those patterns. And he was able to work up to his way to be able to squat 75% of his max max weight that he was able to squat before. And we were able to do some straight line sprinting at about 75 to 80% perceived effort without pain. He could push past that, but it was going to cause more pain. And obviously, we don't want to reverse our process. Cutting and those types of things were still a challenge. But again, we're at the end of 3 weeks. The fact that he can get up to 75 to 80% of a straight line run and 75% of his max weight, that we were pretty happy with that, because now we're 5 weeks post injury, and normally an injury like this you're looking at 12 to 16 weeks. He was very happy. We were very happy. So our next case study, we have a female, 22-year-old female. She's a sprinter, long jumper, and while she was doing practice jumping, she started having severe pain on the inferior pole of her right patella. There was no swelling in the area, but there was a lot of localized tenderness. Had a 6 out of 10 pain, worse when jumping. Obviously, she was having problems climbing the stairs and coming down stairs, or those types of things. So we were able to diagnose her with acute patellar tendonitis, and we did do a diagnostic ultrasound to be able to confirm that. And it showed that she had early stage tendinopathy with a slight thickening of the patellar tendon. So our treatment plan, initially, treatment had been to rest from all high impact activities such as jumping and sprinting. And this is what she started doing before she got to us. She had been taking a lot of NSAIDs for short-term pain relief, and they had a PT program there at the school where she was at. And it was initially focused on eccentric exercises and soft tissue mobilization, but she just wasn't seeing the results that she wanted. So we got her post 2 weeks after rest and some limited progress. So she was referred to us for some extracorporeal shockwave therapy. And the protocol that we set up for her, we did 3 sessions a week over 2 weeks. So a session about every 4 or 5 days is what we were able to figure out we could do with her. Pulses were around 1500. We set the energy level at a low to moderate energy level to be able to suit her, because this was acute, and be able to minimize the amount of injury aggravation that was potential there. So we set it around 80 millijoules, and our frequency was at 8 hertz. We also incorporated, as part of her rehab, we did some eccentric quad strengthening, hamstring and quad combinations to be able to get a lot of that stress off of that patellar tendon. And we did a lot of PNF stretches on the proximal and distal quad muscle groups. We're trying to get those muscles to release and relax. Overall treatment goal was obviously to increase blood flow so we get some neovascularization around the injury site, get hopefully some nutrient and oxygen delivery to that damaged area, reduce the inflammation, which is probably the most important thing, because again, we're dealing with a tendonitis. So it's going to help reduce a lot of that cytokine type inflammation and modulate inflammatory responses when she gets out and tries to do her activities again. You have pain modulation, so we use a low energy. It's going to help reduce pain by desensitizing the nerve endings and help reduce local tension in the injured muscle. So overall prognosis, after the first session, we had about a 20% reduction in pain, less pain when walking and less pain when squatting. After the third session, we had post-treatment. The patient said she was about 60% better from where she initially was. We had a marked improvement in her mobility and progress to low intensity exercises. So we started getting her on a stationary bike, doing some light jogging to be able to kind of get her body moving. And when you have track athletes, they don't like to sit still very long, and they're very, very antsy and anxious to be able to get back to activity again. So we did another follow-up with her at 4 weeks. So she was able to return to light training, doing sprinting drills, 80% reduction in pain, and she had pain on squatting that was almost completely resolved. After 8 weeks, she was back to full training again. My third case here, we have a 45-year-old male marathon runner. I'm glad he can do that. I'm not built for that. All these marathon runners, tall, skinny guys and gals. So definitely not my realm of expertise as far as athletics is concerned. But He had a chronic right Achilles tendonitis for about 2 years, been dealing with it. And the fact that he'd been dealing with it for 2 years was amazing. But injuries, had a persistent 7 out of 10 pain, especially in the morning. A lot of morning stiffness that went along with that, and some increased pain with running. And so he was feeling it right along that mid Achilles tendon. You have to be very careful, especially if they're feeling it right there on the calcaneal attachment. You've got to make sure that you're doing your diagnostics thoroughly on that. And we try to do diagnostic ultrasound on each one of these. That way we can see if there's any chances of a possible rupture. We definitely don't want to deal with that. So unfortunately, he was not in danger of that at this point. His was pretty chronic. So he had a tendon thickening about 2 to 5 centimeters above the calcaneus, and had some hypoechoic changes of degeneration that were taking place. Obviously, I mean, he's getting a little older. 45 to me is not old. I'm older than that. But he's not a spring chicken as far as somebody in their 20s anymore. So we do expect to see a little bit of that degeneration start to take place. Did a little bit of research on this because we knew that a lot of tendonitis had been had some research behind it. We looked at a 2005 study out of the Journal of Sports Medicine, and it found that patients that were treated with this type of therapy had a 60-80% improvement in pain and function after 3 to 5 sessions. And then they did follow-ups at 12 months, showed that the benefits were maintaining. So they had reduced pain and increased tendon elasticity in most of the patients. So I'm like, okay, we can possibly work with that. Prior to getting to us, he had a lot of extensor exercises, doing PT, a lot of eccentric type loading, bracing. Had gone through some corticosteroid injections about 5 months prior. And of course, the pain relief is very short-lived. Corticosteroids, an anti-inflammatory effect, but it doesn't really, treat the problem. It's more of a symptom-based treatment. So after limited progress with both of those in the last 7 months, he was referred to us for shockwave therapy. So the protocol that we set up for him, we had 5 sessions over 5 weeks, did about 1 session per week. Pulses we set around 2,500 because it was chronic and had been there for so long. Energy level was 90 to 130, so we upped it up, amped up the energy level a little bit, and then we set the frequency at 8 hertz. Rehabilitation exercises that we incorporated, we did a lot of eccentric heel drop exercises, some light PNF type stuff, and then limited low intensity, low mileage running. Again, when you're trying to deal with somebody that's a runner, sprinter, track type people, they don't like to sit for very long, and they're very anxious to get back out and start doing their activities as quickly as possible. So we wanted to try to get him out and being able to do those things as quickly as we could. Treatment goal overall was to increase blood flow with some neovascularization because it had been chronic, and we had some degenerative process that had already started to show on the diagnostic ultrasound. So we wanted to get some increased blood vessel and perfusion around that area, be able to promote nutrient oxygen delivery so that we could get some tissue repair in there, reduce the chronic inflammation because of the tendonitis, obviously, and then some pain modulation to help reduce the pain by desensitizing the nerve endings and reducing that pain sensitivity. So prognosis and outcome over that. So after the first session, we saw about a 10% reduction in pain. Again, it's chronic. It's been there for a long while. It's not going to, it didn't get there overnight. It's not going to go away overnight. So we didn't expect to see a tremendous amount of improvement after the first one, but a 10% reduction in pain. He was happy with that, and so were we. So there was a lot less pain when he was walking. And then after the second session, we did a post-treatment. Said he had about a 30% reduction in pain, less morning stiffness, and was, had less discomfort when he was walking. And then after the fourth session, we were able to actually start reducing some resumed light training, low intensity type stuff, 60% reduction in pain. And we obviously always try to do some squat therapy. We do a lot of squat assessment and therapy to build up leg strength. And there was no pain on squatting after the fourth session. After the fifth session, we were up to 75% improvement, progressed to 20 to 30 minutes of moderate intensity. We try to tell them, just do it up to the threshold. If you start feeling pain, that's when you stop. And so that's where we kind of gauge our progress, is their ability to be able to increase their activity before pain onset. Was not experiencing the morning stiffness that he was before in that ankle, and a lot of reduced pain on palpation in the Achilles. So we did a 12-week follow-up with him, and he had already returned to full marathon training and was, symptom-free from that. Last case study I'll touch on, we have a 47-year-old male. It's our weekend warrior type, recreational golfer, like to do a lot of carpentry stuff on the side outside of his office job. Was having some, lateral right elbow pain for about the last 8 months. Injury was a persistent 8 out of 10 on the lateral elbow. Obviously, trying to do anything with tools or holding on to anything was causing a problem. So after doing a diagnostic ultrasound, there was a tendon thickening on the common extensor origin right there at that lateral epicondyle. And so we were able to diagnose it. Because it had been there for 8 months, we diagnosed it as a chronic lateral epicondylitis. So doing some research on that, there was a very recent study, a 2021 study, and it showed that people were showing increases in grip strength and function after just 3 weekly sessions. So that gave us a lot of hope that we were going to be able to turn that around pretty quickly. So after the first week, we did 1 session. So we just did 1 session a week for the first 3, and then we decided to do a booster if it was necessary on week 4. After the first one, we had 2,000 pulses, 8 hertz, and 60 millijoules. And so we had the goal for that was to just get a general start to help reduce a lot of that pain and stimulate some blood flow. Second session, we were going to do 2,500. So we upped the pulses and then increase the frequency up to 10 hertz with 80 millijoules. When we got to the third session, we had gone up to 3,000 pulses at 12 hertz. We figured out that was probably a little too much. So when we came back, we reduced it back down again for the 4th session on the booster one. The rehabilitation that we integrated into that, we did some eccentric wrist extensors with a TheraBand flex bar, isometric grip holds, mobilization for the radial head and common extensor fascia. So we got in there, did a little bit of soft tissue work around the area, trying to stay off of the common extensor itself, and a lot of rest. He liked to golf, and again, when you're doing a lot of carpentry type stuff, we asked them to lay off that stuff for a little while so that we could get, since that was the thing that aggravated it, we wanted to get them to stop doing it, at least for just a little while. Treatment goals, again, we want to stimulate that tissue remodeling, increase the blood flow to that area, and try to reduce a lot of that inflammation and get some pain modulation by desensitizing the nociceptive nerve endings. And then obviously the ultimate goal is to improve their functional capacity. So we want to be able to restore grip strength. We did do a dynamometer test on him to see what his grip strength was, so that we had a measurable to go off of what that's concerned. And then just a general tolerance to repetitive or resisted movement. So we had to help him build up some endurance to that. So our outcomes after the first week, we had a 6 out of 10 QVAS. I definitely wanted to track our progress a lot more intensively with this patient. So grip strength on the affected arm, he was able to get up to 40 pounds of grip. And that was with pain, pain-free. He got up to about 22 pounds. Then by the end of week 3, pain reduction had gone down to 3 out of 10. We were getting up to 53 pounds with pain on our grip strength, and then 38 without. By the end of the week 3, we're down to 1 out of 10, 64 pounds. So we're gradually increasing significantly, gradually increasing. And then we got some significant jumps there in the last, couple weeks that we were doing the treatment. And you can see the dash scores that were going down, and we were increasing on our PSFS. So by the end of week 4, we had 0 out of 10, 70 pounds of grip strength with some pain, but very, very minor, because he was able to do 68 without. So when you're looking at a lot of these devices, these are kind of the general settings that you can anticipate on seeing. This is our device that we use. This is what we had. So our energy levels range from 60 up to 185 millijoules, and you can do adjustments by 10 millijoule increments. The frequency is anywhere from 1 up to 22 hertz. Obviously, that 22 is really on the high level. It's an electromagnetic drive system that we talked about before. We have a 2 million pulse warranty on ours as far as the applicator is concerned. And then we got 3 different tips with ours that in our order. And then the depth of penetration is anywhere from 40 to 50 millimeters. And you get a foot switch so that while you're sitting there having to guide that applicator, you're not having to worry about having to have what you're going to do with the other hand. You got a foot switch to be able to turn it on and off, which is pretty nice. So from there, well, thank you for allowing me to be able to come on and be able to talk. I will back out of this.
Okay, thank you, Dr. McAlister. That was impressive. Some of those case studies were very impressive. Thank you for all that information. I know that you have another commitment at the top of the hour, and if you could just stand by for 1 or 2 questions, I think we can get you out of here. Okay, great. So we have a question by one of the attendees that ties in very naturally to a question that I had that was a little broader. So the attendee says, when would you choose Shockwave over laser and vice versa? We use class 4 laser for peripheral neuropathy. And my broader question is, for people who are newer to shockwave therapy, can you briefly explain how shockwave stimulates healing compared to other non-invasive modalities like laser, as in her question?
Yeah, so I'm a huge fan of laser too. I've got lasers that I use with my patients, but I can confidently say that I've gotten faster results with the shockwave than I have with the laser. And especially with pain modulation, we've been able to significantly decrease that pain. And I actually combine both therapies together. Sometimes I'll do the shockwave, and then we may cap it off with a laser therapy on the end. So yeah.
Are there any other devices or modalities that you can combine shockwave with successfully, or that you've tried?
Yeah, I've done I do a lot of acupuncture, dry needling type stuff as well. And so kind of depend. I don't ever do those simultaneously, obviously. And I don't typically do, if somebody wants dry needling, I don't do that on the same session as I do shockwave therapy. You want to split those up.
Okay.
Yeah.
We have another question here that's a little bit specific, but it says, how do you convert the energy level in millijoules to bars? Our machine uses bars. But I think, Dr. McAlister, the device that you use, the nPulse Pro, it gives you precisely the energy numerical value, so you don't have to do any conversion to bars, right?
Yeah. So here's something that you have to understand about that too. When you're talking about that measurement of bars versus millijoules, with millijoules, this is the amount of energy that we're looking at on the output. So after the applicator is already struck, versus a bar is a measure of the pre-applicator strike inside the compressor. So it's a little bit more difficult to do a conversion with that because you're looking at two different units of measurement and two different time frames as where that measurement is done. So when you're looking at bars, that's pre applicator measurement versus post applicator measurement with the millijoules.
Maybe
Hi,
I can
Gerald.
add on to that.
Yeah. Do you have something to add, Gerald? Hi.
Yes. Hi. Hello. Yes, it's exactly right. As you said, bar is more the input measure. So how much compressed air do I need to accelerate that projectile inside of the handpiece versus the millijoule is the output measure. How much energy do I put into the tissue? And that's actually what we want to measure. So if you go to PubMed, you will probably find a lot of studies that have that millijoule or millijoule per square millimeter even. That is the measure that focused shock waves normally use. But to make a long story short, to convert it from a bar, a compressor-driven unit, it's 60 millijoules equals 1 bar, and then it goes normally up to 5 bars, and that would be equally to 180 millijoule. And our unit goes to 185 millijoules, just slightly above.
Makes perfect sense. Thank you, Gerald. It looks like we have you for about 2 to 4 more minutes, Dr. McAlister. So I'm going to sneak in another question here.
Okay.
So I don't think you got to this at all. I don't recall this in your presentation. So what is the feedback like from your patients, both during and then after? What do you hear? What do they say about the sensation and then also just the way they feel?
So it's interesting. I've gotten a variety of different feedbacks from patients on that. Obviously, the ones that are really, really acute, they're going to feel it a little bit more. There's get more discomfort. And
Hmm.
my approach with those, especially when that severe hamstring injury that we had on the first case that I talked about, um, I tend to work the area around the injury site first, and then kind of work my way into tolerance over the site of injury. A lot of our chronic conditions, they don't know, there's no pain that they have experienced with that they've given me any feedback on. Some of the tendonitis ones, like the lateral epicondylitis, his was pretty inflamed. So again, I kind of worked the area around it and then gradually worked my way over to on top of the injury site. That's kind of my approach. So the idea behind that is I desensitize the area around it, then gradually work my way into it to desensitize that area, if that makes sense. I've had some people that say they feel it's almost like a tingling sensation. Some of them have talked about a tingling sensation with that. Um, and then I've had some of them that said that, all they feel is just the pulses going in. And that's all they've said. So it's a variety of different perceptions.
Okay, last question. You did get into reimbursement just a little bit, but I know it varies based on the state.
Yeah.
From a clinical and communication standpoint, how do you discuss shockwave therapy with patients when insurance doesn't cover it? And do most patients feel that the results justify the cost out of pocket?
Yeah. I could definitely say that the patients have said that the cost justified the cost. There is a variety. So I could give you what we do down in Texas, but that may not necessarily apply to what
Right.
the average cost is in Wisconsin. So and there's some variety across the United States. I've actually asked Gerald that several times. I said, hey, what's the kind of the average prices? And he said that the range is kind of all over the place depending on where
Mm,
you're at. And but I could tell you from our standpoint, the patients, because they've recovered so quickly and we've been able to get them back into play. I treat a lot of football players with hamstring injuries, and the fact that we're able to get them back on the field in a week rather than having to sit
mm,
out, 2 to 3 weeks. Yeah, they definitely they're
yeah,
definitely happy for the results, and so are the coaches too. So
sure.
yeah.
Oh, great information. Thank you so much. Are there any final thoughts before you leave us here? You've given us so much already. I'm sure it's a lot to absorb for our attendees. Any final thoughts, Dr. McAlister?
No, I mean, we always want to do what's best for our patients, and we want to bring the things that's going to,
Yeah.
you know, it's going to treat our patients. And when we came across this, it was an absolute game changer for us as far as being able, especially because I work primarily with a lot of athletes, but even still, your older populations or your weekend warriors, yeah, it's been huge. So I would definitely encourage people to look into it. And if anybody has any questions, they're more than welcome to reach out to me. So
Excellent. Yeah. Well, at the end of this presentation, Dr. McAlister does have to go now, but at the end of this session, the course, we
mhm.
will give information about how people can get back into contact with you with any follow-up questions. So thanks so much, Dr. McAlister. It was it was so informative. Thank you.
Thank you.
And thank you. And that concludes
Thank you.
our first hour's presentation on shockwave therapy. Thank you again to Dr. McAlister. And now we'll take a short break. And before the next hour's presentation, Gerald Gable, who you see here. Hi, Gerald. He's Zimmer
Hi,
Med.
everybody.
Hi, he's Zimmer MedizinSystems Vice President of Sales for Physical Medicine, and he'd like to add a few words about the nPulse Pro shockwave system.
Thanks to everybody for having me on today. Happy to be here. And I promise I'll make it short. I just wanted to add a couple of more in-depth details about our system and show what it can do, why is it so impactful and forceful. Um, and here we go. I wanted to start off with a short video actually that shows a little bit of the impact force of that system. We're talking about the nPulse system here. What you can see here is a €2 coin that is accelerated by the transmitter plate. That is the piece that you will have on the skin with skin contact with the patient. And the €2 coin, to make that a little bit more clear, it is the heaviest of the euro coins. It's probably almost twice the weight of a quarter. And you can see how easy that is accelerated into the air because of that impact force. And many of you might ask, how is that possible, or why is that possible? And the answer to that is in the laws of physics. So some of you might remember the Newton's law of force, impact force, and that is, you can see here on top of the slide, force equals mass times acceleration. That is what makes force. And here, when it comes to shockwave, that is important because, again, we're measuring the impact force in millijoule, the energy that we're putting into the tissue. And also, one important point is shockwave therapy is often discussed by people, oh, it's painful, it's uncomfortable for the patient. But with our drive system and the electromagnetic drive system, we actually can make it a little bit more comfortable for patients. We call that the so-called soft shot technology. Why is that soft shot? Because with electromagnetic drive, we can use a 5 times heavier projectile, and you can see the 2 projectiles down here. The one on the left, the small one, is the one that is normally used in a compressor or a pneumatic system, which are 95% of the systems are compressor-driven systems, versus on the right, you can see the 5 times heavier projectile that we can accelerate with our electromagnetic drive. What does that do? The red curve here is a fast rise and a fast peak because it needs to be accelerated so fast, that projectile. And that is what feels snappy and painful for the patients on the skin. And we don't want that. That's why we use that bigger projectile, and we get to the blue curve, which has a slower rise and then a fall. And also you have that negative pressure that Dr. McAlister spoke before, but it feels more comfortable while having the same impact force and delivering the same amount of energy and also the same amount of depth. That is more important. Actually, in some cases, even more depth, because you can increase the energy higher than you normally can do with a compressor-driven unit. Yes, so you can kind of visualize that in terms of a metaphor, tack hammer versus sledgehammer. The compressor-driven units are tack hammers. You need to accelerate that tack hammer pretty fast to get a nail into the floor, versus the sledgehammer, you just let it go, and the weight of the hammer does the work and puts the nail into the floor. It's really very efficient to transfer the energy from the handpiece into deep tissue structure. The treatment is more comfortable for patients. We give 2 million pulses warranty. And again, this is only the warranty. If you clean that handpiece out on a regular basis, take the transmitter head out, clean it out with a Q-tip, these handpieces are maintenance free and they live forever. I have seen handpieces with 20 million, 25 million shots and still running like a charm. So you don't have any handpiece rebuild kits as you would need for compressor or pneumatic systems, where you need to replace the bullet and the pipe system and all that kind of stuff. That is costly. Practically no maintenance. Yep. And all in all, really, that is a system, a modality that you can have in your clinic. And the big advantage, it gives you a positive cash flow here after the first patient per month. To make that more clear, normally the charge for shockwave therapy is somewhere between 50 to 150, so the spread is quite big per session. And then you would do 3 to 6 sessions, or 3 to 10 maximum normally in a treatment package. So that gives you around $300 to $500 per patient per month. It's not a hard sell. It's just giving your patient alternatives to other options like long physical therapy exercises or steroid injections or medications, which they already wanted to have and want to use. Faster recovery for athletes, alternatives to steroid injections and medication already mentioned, and in some cases, even an alternative to surgery. And of course, more important, marketing for your clinic. Nowadays, every patient or almost every patient is online Googling, getting tips and tricks from other people, neighbors, other athletes, weekend warriors they do sports with, what to do. And Shockwave is one of the things that comes up. If you Google it for certain indications, even if you ask AI, it comes up as one of the top things to do. So if you have that on your homepage, in your services drop-down menu, that is important to have. So last slide, and then I'm done with my sales spiel. Special leasing available. This one is a special offer for WCA, and it's valid until the end of October. So if you're playing with the idea of getting a Shockwave device, get one until the end of October. We have the mPulse 2.0, which is the tabletop version. It's the smaller brother of the unit that Dr. McAlister is using. $0 for 6 months, and then $345 per month for 5 years. And again, with that, you will have no payments until April, but you will get revenue into your clinic. So that's awesome. mPulse Pro, the same deal, $0 down for the first 6 months, and then after that, it's $395 per month. And that is it already from my side. I just wanted to mention, if you have questions, if you want to go through the numbers, maybe you say, oh, I can charge so much in my area. I feel that I can get so many patients in with that therapy in my area or in my clinic. Give me a call. We can go through the numbers. We have an ROI calculator where we can put all your individual numbers in and then see what comes out of it. And also for any other questions, that is my direct number that is displayed there. So give me a call or write an email to info@zimmerusa.com, and I'm happy to help.
Excellent. Thank you.
I'm
Thank you
handing it
so
over
much.
to Gina and Dr. Wijting.
Now we're ready to launch into hour 2 of the session with Dr. Wijting. We'll give him just a moment to set up his slides here. And hello, Dr. Yorick Wijting. Welcome back.
Hi.
So we'll launch into Dr. Wijting's presentation on high energy inductive therapy, but let me refresh the audience on some of your background quickly and share a little bit more about you, Dr. Wijting. You heard what I said in the intro at the very beginning of the webinar. And Dr. Wijting is an accomplished clinical educator and practicing doctor of physical therapy based in Gilroy, California, where he operates his private clinic, Specialist Physical Therapy. He brings a unique perspective to his practice, viewing his role with his patients as a facilitator. Knowing that the human body always tries to heal itself, he uses his hands, knowledge, and a range of therapeutic devices to aid in the natural process. His practice is equipped with advanced equipment to enhance rehabilitation efforts, including shockwave, laser, mechanical traction, a dynamic exercise platform called Huber 360, and wireless nystagmography, and high energy inductive therapy, which we're here today to talk about. His practice has transitioned from insurance-based to a cash pay business model. And Dr. Wijting, we are eager to hear your presentation on high energy inductive therapy, a review, case studies, and treatment strategies.
Thank you, Regina. Hello, everybody. I'm hoping that you have enjoyed it so far, this talk. I'm going to focus on high energy inductive therapy. It's a therapy that I started using a number of years ago. The first device that I came into contact with is the device I still use today, the one from Zimmer, MedizinSystems. So it's a fascinating modality, and I hope you'll learn something from it. It's been my experience that most people are less aware of this than they are of shockwave therapy. So this might open some interesting opportunities to you. It certainly has for me. just some background so that you can kind of see where I'm coming from. As you heard, I'm a physical therapist. I am now in private practice. I run a small solo practice. It's just me. I'm in the fortunate position where I have access to a lot of modalities. I was trained back in Europe, in the Netherlands, to work with modalities, kind of like a tradesman would work with power tools. It's the view that I was taught and that I still use today is that the right device for the right condition can dramatically improve the effect that I get from the combination of all my interventions, which of course includes exercise, it includes manual therapy, it includes whatever I can do. So it's a cocktail of interventions that I throw at my patient, and the devices that I use in that respect are really enhancing the overall effect. So I use it, I look at them as a force multiplier. There's many conditions where I cannot achieve the right thing or the right effect without these devices. So my devices are always in use, and high energy inductive therapy as such is a device that I use really a lot. At least 50% of my patients, actually it's probably more, 60 to 70% of my patients get a treatment or get a session with this device for reasons that I'll explain in a moment. Okay, I'm gonna go. I will share for maybe 30 minutes or so, and then leave enough time for questions. Specific to the questions, by the way, I use shockwave therapy as well. I use both radio and focus shockwave. I'm totally in love with the modality, and I thought Dr. McAlister did a really good job presenting it to you. Specific to the questions that came up regarding how do you decide whether to use shockwave versus laser, the way I look at it, because I have both of these devices as well, and the way I choose, I look at shockwave as uniquely able to deliver a mechanical disruption to the tissues. So depending on the power that you use, you can really affect the integrity of a scar, the integrity of a bone spur, which is unique to it. It's a powerful pressure wave going into the body. And it also has a very unique, powerful effect on circulation. There's an angiogenetic effect to shockwave that is very unique to it, and that cannot be achieved with anything else. So the increase of the circulatory network and the direct mechanical effect on the tissues, if I need those for my patient, then I will gravitate to shockwave. If my focus is more on accelerating the metabolism through an increase in ATP production in the cells, and my tissues are at a relatively superficial level, then I will start thinking laser. Now, of course, there's an overlap, especially when you look at the biological effects that both of these have. There's an overlap, and many times I use both of them, one after the other. And we can talk about that later, because the same applies to high energy inductive therapy. There's overlap similarly. So anyway, we can talk about that towards the end. So let's talk about high energy inductive therapy, or HEIT. What is it? It's the application of a low frequency oscillating electromagnetic field to the treatment area. So I'm delivering a magnetic field that is not a standing magnetic field, meaning negative on the one side, positive on the other side, like in an MRI machine. In this case, it oscillates. So there's an oscillating field that penetrates into the tissue, and the power of this field is very high, similar to an MRI scanner. In the case of the device that I use, the Zimmer device, it's up to 3 Tesla. So it's a very powerful device, and it creates an oscillating electromagnetic field, with the main emphasis on this field being magnetic. What does it do? And I'll get more into details as to exactly how physically this works. What does it do? What does this magnetic field do? It elicits biological effects in the tissues, and it is able to evoke muscle contractions in both superficial and deep muscle groups. Both of these together create a very unique treatment effect, which I'll explain in a moment. How do you apply it? How do you use it? It can be applied either in an unattended or attended fashion. When I say unattended, I mean the device is over the patient. It is being held in place by an arm that is connected to the device, so the applicator is over the treatment area. The device is started, and at that point, I, as a clinician, don't need to attend to it anymore. I can just let it do its thing on the patient, or I can grab the applicator myself in my hand and move it over the treatment area while it is running. So in that case, it's a more hands-on, more attended session. So both of these are, of course, very useful, especially the unattended mode is very useful. The second unique feature of its application is that there's no need to disrobe. So the effects that you want to achieve, either the biological and or the muscle contractions, they are achieved without really needing to take off any clothes. It will go through the clothing, it will go through any layer of tissue and penetrate the body. The only variable there is the further away you are from the body, the more decay you get of the magnetic field. So the weaker it is and the less penetration you get. So you still want to be close to the body, but you do not need to have direct skin contact. So that's a big plus. Let me go to the next slide here. Now, this is not, even though in the rehab professions, this is not a quote unquote new application. In fact, in the psychiatry world, it has been in quite a lot of use and a lot of research in the form of transcranial magnetic stimulation, TMS. In that instance, you deliver the magnetic field over a specifically targeted brain area in order to work on psychiatric issues like depression, for example, but you could also target it towards the motor cortex in order to promote recovery after stroke. There's a variety of applications in that particular form, but it is an application that has been around for quite a while in this field. So it's neurology, psychiatry, etc. Most of the work that you'll find in the research, when you go looking for what kind of research is there available on this application, most of it you'll find in this particular form of it. So in this instance, they target a specific brain area, they fix it in position, the patient stays in that position, and then the treatment starts. Other than that, it's exactly the same thing. It is an electromagnetic field, it's an oscillating field, and as a result of that oscillation, you get depolarization in the sensory and motor cortex areas. So the nerves react, essentially, to the field. And I'll explain exactly how that happens. And that nerve activation or deactivation, facilitation or inhibition will then deliver the effect that the researchers or the clinicians are asking for or are looking for. Now, before we explain exactly how this works, how best this works, where does this fit into the electromagnetic spectrum? Because there's other electromagnetic devices that we use, both in daily life, but also in therapy. Shortwave diathermy is one that I have used a lot in physical therapy. And there's others. Light, laser is also a form of electromagnetic frequency. So where does this fit? I already mentioned that it's a low frequency application. In fact, the research calls it an ELF, an extremely low frequency application of electromagnetic energy. And when I say extremely low frequency, you're talking about below the 150, 250 hertz. So the pulses that are delivered, the oscillation of the magnetic field, are in that very low range. That very low range is then followed by ranges that are higher, that are maybe more common to PEMF, the way it has been marketed nowadays. Those are typically low energy applications, and they tend to have higher frequencies than this one that we use. And then after that, you get to the radio waves. So the shortwave diathermy falls in the radio wave. This is now, we're talking millions of cycles per second. shortwave diathermy. If you go a little bit higher, microwave diathermy, which is not really used anymore. And then you get into the light ranges, infrared, visible light, ultraviolet, etc. And that's pretty much where the therapy spectrum ends. If you go higher still, you'll end up with X-rays, etc. So anyway, this is on the very, very, very low end of the spectrum. Why is this important? Is the higher end of the spectrum, especially the shortwave diathermy and the microwave, the main effect of those, even though there is a non-thermal effect, but the main effect is thermal. Because of the speed of oscillation, you get a vibration of the particles inside the body that the wave is applied to, and that rapid oscillation of the particles creates friction and thereby heat. So heat is the main therapeutic effect that then mediates further biological responses, such as increased circulation and etc. In this instance, heat is not a factor. You are not going to heat anything up with this application. So I mentioned PEMF. PEMF stands for pulsed electromagnetic frequency. The pulsed electromagnetic frequency is a generic term, and it's kind of been appropriated by a specific type of PEMF, which is the low energy ones. You see some examples in the picture on the right here. Typically, these are marketed to accelerate a healing process, to have a beneficial effect on tendon healing and what have you. The key characteristics, regardless of the application, and it's been used in the human field, but also a lot in the veterinary field, the key benefit here, or the key characteristic here, is its very low intensity compared to what we're talking about today. In terms of field strength, you're talking about less than 70 microtesla, 1/1,000,000th of a Tesla, less than 70 of those. Whereas in the field strength of HEIT, we're talking over 2 Tesla. So it's a much more powerful application. You will therefore be able to elicit the response in both sensory and motor neurons. So you're going to feel it, and you're going to see a muscle contraction, which you cannot get with the traditional PEMF applications. Therefore, you're able to elicit a strengthening effect, which you cannot with PEMF. It will also be able to go much deeper than traditional PEMF. In both of these applications, you don't get any heating. You also do get a facilitation of the metabolism. The difference in terms of where you would get this metabolic effect, of course, in HEIT, you'd get a much bigger such effect because you go deeper, much deeper than in the PEMF. So this is, I think, a useful thing to keep in mind, because a lot of vendors out there will tell you they're selling electromagnetic applications, which they indeed do, but it's really not the same thing. You're talking about a totally different kettle of fish. All right. On the left, you see a picture of an applicator over a knee. This is the HEIT application the way I'm using it. It's an applicator that is either held on an arm or it is held in a hand. The energy comes out underneath and penetrates into the body. On the right, you see an illustration of how that field would look inside. And of course, it's just an illustration. It will be able, that's the take home from this, because of its strength, it's going to be able to penetrate into the muscle deep down inside of the body. Essentially, there is really no muscle that is out of reach for your application with this, which is one of the big benefits that I'll highlight here in a moment still. So even deeper muscles, think deep hip rotators, deep segmental spinal stabilizers, pelvic floor, you name it, they're all accessible to this form of stimulation. Now, how does it work? I mentioned it's a oscillating magnetic field. The oscillating magnetic field is generated by current that runs in a loop inside of the applicator. So there's a coil inside the applicator. The current will run one way and back out, and then it will run the opposite way and back out. So the current direction switches regularly throughout time. Because it switches, it elicits a magnetic field that is perpendicular to the direction of the current. So these coils, in this particular illustration, you see these blue arrows, they flow one way, and then they flow another way, and they flow one way, and they flow another way. And they stretching out at a distance from the coil. So because this coil is in the applicator, which is over the body, these oscillating fields, these oscillating magnetic field lines are penetrating through the skin, through bone, through muscle, and they flow through it. What do they do inside of there is, in turn, because the magnetic field is flowing, if you remember your physics class from high school, an oscillating magnetic field will elicit oscillating currents around the field lines in tissues where these currents can flow. So if you have a moist tissue like a brain or a muscle or any fluid-filled cavity, current flows easily through them because of the high humidity content, and there will then be current flowing because the magnetic field changes constantly. Now, these currents that are created or triggered or evoked is the proper term. These current flows are called eddy currents, and these are your vehicle to achieving your effect. These eddy currents will trigger a variety of biological effects, but the main ones are the following three. First of all, as a result of this effect, you will get an increase in the membrane permeability of the cells. Second, you will get evoked nerve depolarization in motor neurons and sensory neurons, but the motor neurons is the main effect. And third, you will get an increase in the fluid motility in and around the cells. So things start moving around, in and around there. All three of them have some real significant potential therapeutic benefits. So let's tackle them one at a time. The increased permeability. A cell membrane acts as a barrier, as a gate. It is very effective at doing that, and it will allow a certain amount of exchange between its inside and its outside of the cell through specific channels. These gates or channels can close or open depending primarily, or at least in the case of the gates that we are interested in, primarily on the voltage. So these are voltage controlled gates. They will open up when the voltage is just right, and then they will close when the voltage changes. Now, in the case of an inflamed cell, what you will often see is that the cell, if you were to observe it in a microscope or you observe its activity level, you will see that it's sluggish, its activity level is depressed, and its voltage activated gates are closed. In other words, what is inside the cell cannot travel out, and what is outside of the cell cannot travel in, or at least not as much. This is universally recognized as a problem, and we are targeting it frequently with electrical current in order to trick these cells to change, by changing the voltage across the membrane, by trick them into a more healthy state, so, or at least a more open state. So there's an exchange of nutrients occurring across the membrane when the voltage is right or when an external current is applied to the cell. Now, this can be done with an electromagnetic field, like in the case of HEIT. So applying HEIT over an area that is inflamed will immediately change the dynamics by virtue of this effect. So I often say this to a patient when I try to explain what I'm doing. I'm saying, okay, imagine this shoulder of yours is inflamed. You've got a bursitis because of this itis, because of the inflammation. The cells inside you are not, they're kind of depressed. They're sluggish. They're not exchanging nutrients. They're not kicking out their waste products. They're not absorbing the nutrients that they need to heal. That's a problem, because in that state, whatever we throw at you is not going to work very well because the cell is not really benefiting from it in that state. So applying this machine will open all of that up. You'll get essentially, you open a window of opportunity where the cells can exchange, they can heal, they can get in on the act of healing. And that's usually an explanation that people can get. Second, you will be able to deliver or to evoke a certain amount of muscle contractions. Muscle contractions are beneficial, of course, for a whole host of things. Where I typically see the biggest benefit of evoking a muscle contraction is by making a muscle contract that normally does, or in this situation, the patient doesn't want to contract, maybe because of pain, maybe because of a certain amount of neural compromise, a stroke, a peripheral nerve injury, whatever. There are certain conditions where the muscle is not working quite as well as it should, or it's not wanting to work for whatever reason. In this instance, you can trigger a contraction with an externally applied current. Now, of course, HEIT is not the first one to do that. We've used surface electrical stimulation, NMES, forever. The problem with NMES is that the current has to be pushed in through the skin. And as it's pushed in through the skin, you get a strong sensory response, which becomes a bit of an obstacle to deep penetration, because as I'm increasing the current to go deeper, I'm also getting a much stronger sensory response, and eventually the patient finds this very unpleasant. That problem disappears with HEIT because the eddy currents are strong enough to evoke depolarizations in the motor neurons without necessarily provoking a very strong response in the sensory neurons in the skin. Why? Because the muscle is a moist environment, whereas the skin is a dry environment. So the strongest current flow will happen there where you need it. Now, unique to this particular device is the strength of the field, meaning you can go, by cranking it up, you can go deep. So I've put some images here on the left of deep muscle groups that I find particularly interesting to work on, because I can't work on them very well, very effectively because of their depth with surface stimulation. So the multifidus, the deep segmental stabilizers in the spine, the rotator cuff muscles, the hip stabilizers, the deep hip rotators, and the pelvic floor. They're just examples. Very easy to actually act on them with HEIT, whereas with NMES, it's going to be much, much harder to do that. And then, of course, disrobing is not necessary, especially in the case of incontinence where the pelvic floor is a target. This is a real big benefit. You don't need to use any invasive electrical stimulation, and you can just have the patient sit in a seat and sit on top of the applicator and start your treatment. More about that example in a moment. And then third, so we spoke about, number one, the increased membrane permeability. Number two, muscle contractions. Number three, increased interstitial fluid motility. The fluid inside and outside the cell is mobile. There's a certain motility to it. Molecules can move, and as a result, there's movement in the fluid. These molecules many times are mobile, or they move as a result of an electric field that is applied, or a magnetic field that is applied to them. So I get kind of a sloshing around effect inside there. That sloshing around will enhance the delivery of nutrients that may need to get into the cell or may move out of the cell. So all that motility and the enhanced motility is beneficial to the various biological processes that are happening there, especially the exchange of electrolytes. The other thing, which there's not a lot of research on yet, but I am firmly convinced that this is a huge effect or a huge benefit, is this third bullet here. There is, in many chronic conditions, a certain stasis of tissues. The swelling stays, the motility inside is not adequate, so you get more adhesions. Everything is like congealed chicken noodle soup. Whereas if it could just be more fluid, move, then my range of motion would improve, my healing would accelerate, etc. This process of stasis is directly countered by applying HEIT. So it's a big, big benefit. Okay, we're going to jump into some examples here very shortly, but before we do that, let's look at the outcomes, the way they're listed, and what you can expect based on the effects I just described. You should expect to see improved cellular metabolism. You should expect to see decreased inflammatory signs, and you should expect to see an effect on strengthening, recruitment, and tone. So the muscle function will benefit from it by getting stronger, by activating quicker, easier, and by developing a more normal tone. The FDA has cleared the typical indications that result from what I just mentioned. So you'll see on the documentation an effect on muscle spasm, disuse atrophy, improvement of local circulation, muscle re-education, thrombosis prevention, and improvement of range of motion. All of those I know are fairly generic, so we'll go into more specific here in a moment. Precautions, contraindications, there's a couple of things that you really have to pay attention to. Do not apply this over any implanted electronic circuit. So a pacemaker, a deep brain stimulator, vagal nerve stimulator, all of those things do not apply. This is a strong magnetic field and there's a possibility of interference. Do not apply it directly over cardiac tissue. You might just mess around with the rhythm of the heart. Do not put it directly over active neoplasm, either benign or malignant. You don't want to accelerate tissue growth in those instances. And don't put it over the anterior neck because of the possibility of stimulating the carotid reflex and activating the intrinsic laryngeal muscles, which would cause your airway to close. Other than that, everything is a precaution. Glands might get hyperactivated, so be careful there. Don't apply it over open growing epiphyseal plates, growth plates, because they might start growing a little bit faster. You might get asymmetry in growth. Active bleeding disorders may bleed a little bit more because of your increased contractions. Seizure disorders may increase because sometimes the sensory effect is fairly strong. And you want to be careful over ferrous metal, anything that is considered ferrous or has iron components in it, because it reacts to the magnetic field. And it's essentially simplest to simply ask, your implant, is it MRI safe? If it can go into an MRI, you can treat it with HEIT. All right, let's tackle some examples. I'll show you some examples from the evidence. The way I typically work with things is similarly to what Dr. McAlister, the way he approached things, is try to find some article in the literature that talks about the condition that you need to treat, and there get your starting point. This is how we're going to do it. Let's see if it works like it is described in the literature. I've kind of cherry-picked the literature a little bit in the examples I'm going to mention to you because it's kind of my personal experience with these. So I'm only to say that there is much more out there in the literature on the subject, but these are some big ones. Segmental instability. This is a condition where, of course, you all know this. You are experts in this field. The multifidus, the intrinsic muscles in and around the segments may not fire well enough because of pain, maybe after injury, after surgery. The goal here of using HEIT is to improve muscle recruitment and dynamic stability. It says here the knee, ignore that, that's a typo. The dynamic stability of the segment, of the spinal segment. What would be the rationale? You're going to deliver, of using this device, you're going to deliver evoked contractions to decrease the reflexive inhibition that is occurring. So the patient may not be using their multifidus properly because of the pain, because of the problem that they're facing. Now I put this machine on there and that muscle will fire. I then typically, and the literature says the same thing, ask the patient to work with the machine. So when the muscles contract, try to do a volitional exercise at the same time that activates that same muscle. So you essentially, by use, retraining the circuitry to start volitional recruitment of that muscle group as well. So the patient may be sitting or may be lying down. The applicator, here again it says vastus medialis, but what I mean is here is the multifidus, evoke some passive contractions for the first half of the session and then follow it up with concurrent volitional contractions. So at the same time, I'm asking the patient to recruit. So it could be they're laying on their stomach, the applicator is over the L3, L4 segment, the contractions are being felt and I can see them very clearly. As the speed of the contractions increases, I say to the patient, okay, now you feel that? Right, now raise your right arm, hold, and drop it down. Now raise your left arm, hold, drop, whatever. You get the picture. So this could be either in an attended or unattended fashion. In this picture, you see the therapist holding the applicator over the segment. This is thoracic, but it could be lumbar in this example. I often use it with the applicator mounted on the arm, so I find it a little bit easier to operate the applicator that way. But it's useful to be there because you can be specific to that segment. Works really, really well. Knee surgery, this is the same rationale. Here, of course, you want to improve the muscle recruitment over the knee, typically after surgery. So the vastus medialis may be inhibited because of pain and or surgery. The same thing, I want to overcome the reflexive inhibition. The patient in this case will be sitting or laying down again, or sitting in long sitting on the treatment couch. Applicator is over the vastus medialis typically. Again, I start with passive contractions for the first half session, could be 10 minutes, and then work with the activation, with the stimulation, and contract volitionally as hard as possible together with the machine. 20-minute sessions, 2 to 3 times a week for 3 weeks, works wonderfully. These are some example shots. You get the picture, applicator directly over the muscle, crank up the juice, get the contraction going, and start your treatment. Subacromial bursitis. Here the goal is to decrease inflammation and decrease swelling and pain in order to improve the biomechanics in and around the shoulder. The benefit of using HEIT is that it's the only tool available to achieve this goal at depth. You know, more superficial, I might have pulled my laser out of the cupboard, but in this case, that is too deep. Laser can't really get there properly. So HEIT is the way to do it. Patient would be sitting, arms supported in the maximally loose packed position with the applicator either anterior or posterior shoulder. 20-minute sessions, 2 to 3 times a week for 1 week, maybe 2. I have often in this instance seen immediate benefit right after the very first session where the patient says, oh my goodness, this feels much better, which I attribute to an immediate decrease in the amount of swelling that's inside of that joint. Tendinopathies, I use this a lot. Achilles tendon, it could be the lateral epicondylitis. Here, what I want to get is a decrease of the inflammation and accelerated healing activity. The decrease in the inflammation will, of course, decrease the pain and swelling, which will in turn accelerate the healing process or make it more possible. Directly applied over the tendon, again, 20-minute sessions, at least twice a week for however long I need to. And the applicator is held directly over the inflamed tissue. I will mention in a little bit that, you know, I often do not only do this, but I use it in conjunction with shockwave therapy, for example. I'll explain that here in a moment. I'm almost done with this. Brain rehab, I haven't done this much. I have done it a few times with some very interesting results. Now, this is, of course, the field that I mentioned right in the beginning, where you apply it directly over the brain. You could want to improve coordination or improve activation in the case of stroke. The rationale is that it's been discovered that if you deliver a high frequency, 10 pulses per second, directly over a cortical area, you will stimulate the activity level of that tissue and thereby improve the recruitment of the muscle that's at the end of that circuit. So the patient will be sitting, the applicator is over the cortex or the cerebellum, and they will be practicing tasks, either contractions, so hand movement, or actual coordination tasks during the stimulation. This would be done for 15-minute sessions, up to twice a week for a few weeks. The positioning of the applicator here is important. So you need to know which cortical area or which tissue you want to work on, and then place the applicator accordingly. Then the last one, urinary incontinence. This is where you want to work on the pelvic floor muscles to improve their ability to maintain tone. You want to work the muscles volitionally at the same time that the evoked contractions are occurring. That is a very well-established, evidence-based principle. Kegel exercises while the stimulation is happening. The patient is sitting on the applicator, maybe with a towel in between to make it more comfortable. And then when they feel the current, when they feel the contraction, the pelvic floor is activated, they will work with it, either with the holds or the flicks. Look up your Kegel exercises and you'll see how to do those. Works very well. There's a decent amount of research in this field. This is what it will look like. I don't have a special chair, but special chairs are available. I essentially put the applicator down, like in this illustration number A, and put a thin terry cloth on top, and then the patient sits right onto it. So that is, I wanted to stop in time to give you some opportunity for questions. But before I do, I promised that I would talk about the combination of modalities. The very successful combos that I now use all the time, and I'll just talk off the top of my head. Achilles tendonitis, I now almost exclusively work on it with radial pressure wave therapy, the way Dr. McAlister was explaining it, followed by HEIT. So I use the M-Field Pro immediately after Shockwave, and that combination has dramatically improved my outcomes. It's a subjective observation, but it's powerful enough for me to stick with it. So I'll do that combo. I have tried the combo of shockwave therapy and laser for that same indication, but I find this combo works better. I think because of the stasis that is a very dominant effect in the Achilles tendonitis, especially the very chronic ones. And I think that HEIT works to mobilize that, which benefits the overall effect. Muscle recruitment of vastus medialis in the knee or the multifidus in the spine. I use the combo of HEIT plus exercise, so not another modality. Works beautifully. Very well-established chronic trigger points, especially the deep one. I used shockwave therapy together with HEIT. I have started experimenting with replacing shockwave therapy with high-power laser, followed by HEIT, and I see good results there too. I'm thinking that laser may have a more powerful effect on point stimulation than the shockwave in certain trigger points, but I'm not 100% sure whether that's trigger point dependent or not, but I'm just observing some of these effects. So those are just some examples. The way I think of these modalities, like I said earlier, shockwave therapy is very unique in the sense that it has a very strong mechanical effect and it promotes angiogenesis. So if I want to achieve that, I will gravitate to that modality. Laser, in terms of increasing metabolism, is very effective. The downside of laser, its effect is not as deep as shockwave or especially HEIT. HEIT is very effective at going deep. It's totally unique at being able to elicit a powerful muscle contraction deep down, and by promoting this motility of the interstitial fluids. So those three together really create some unique opportunities, and you can work by combining them depending on what you're faced with. So I'm going to stop this share right here. Okay. And then leave some time for questions.
Okay, excellent. Thank you so much. And thanks also for bringing back some more of that physics PTSD that Dr. McAlister and even Gerald brought into their presentations. Just a little bit of physics today. Okay, so we will do some Q&A here, just a little bit of time for that, but very quickly, before we get to that, please stand by, Dr. Whiting. I believe Leah of Wisconsin Chiropractic Association has a very short poll for the attendees to complete as a part of this course, and then we'll get back to Dr. Whiting for a couple questions. Leah?
Yes, thank you. The webinar word for today is therapy. If you could type that in, I've launched the poll. It should be on your screen. Type the word therapy and you will be all set. Thank you so much.
Thanks, Leah. Okay, let's get to a couple of questions here while we have a couple of moments. We're almost done with the entire course. So many questions came to my mind as you were going through your presentation. Just to go back, I don't want to spend too much time on Shockwave and HEIT as a combination therapy, but you mentioned Shockwave first, and then you follow it up immediately with the HEIT therapy. Why in that order specifically?
My thinking is that, for example, if I want to mobilize a scar, the scar itself will be quote unquote broken up or affected by the mechanical energy. And now I've created maybe a low grade inflammation there. I've created a certain amount of shear force. Some of the fibers will have snapped. Now I would like that motility that I mentioned earlier. I want things to move around. I want the contractions to deliver also an improved resorption of fluids. So whatever's been activated by shockwave will get maximized. The effect will be maximized by HEIT. I don't think that effect would be as strong if I reversed it.
Right. And for those who haven't had a demo with one of these devices, can you tell me what it sounds like and what it feels like for the patient? Is it, wonderful. Let's get a demo.
Got it right here.
I thought we were going to do sound effects.
Well, I was going to do that, but since I have it right here.
Excellent.
So,
even better.
Applicator is right over my forearm. It starts.
It's going now, right?
It's going now. So
Yeah.
you hear the clicking.
I don't hear the clicking, but but it's kind of it's very quiet. It's not intimidating for the patient, in other words.
So essentially what you hear is click, 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 and then it will, depending on the program that you run, it will speed up. I'll just let it run for one cycle. So this is, now it speeds up, click, 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 etc. So this was at 10% of power, 10, 15%. So on the forearm, it's not very deep, so it's easy to get that response.
Yeah, you weren't moving at all. That was just the response to the device. Yeah. Very nice. Thank you for that. Here's a question from an attendee. Could this help with a chronic rotator cuff injury? The patient does not want to consider surgery at this time, and there is atrophy.
Absolutely, yeah. Definitely.
Yeah.
So the two issues there, the chronicity and the decreased use over time will make the application of this great, because you can now get muscle contractions going that haven't been going for a while, and you can easily get to the muscles. The injury itself, depending on how much of it can actually heal, and that of course is dependent on the severity of the tear, the healing will be able to happen better and quicker and more completely with HEIT versus without. So this, all the effects that I mentioned before, they will be possible with HEIT better than without. So yes, absolutely. It's definitely an indication. I use it for this kind of patient all the time.
I personally have heard some real miracle stories about this therapy. Patients who were unable to walk, who were bound to a wheelchair, then had this therapy for a short time and it succeeded, where surgeries and years of physical therapy could not succeed. So real miracle stories. It has been a lifesaver. So what kind of feedback do you most often hear from patients after HEIT treatments? What have you heard?
Well, they love it. I mean, there's many patients who say they feel better immediately, and that's, that's partly it's the effect of the contractions, and it's universally positive. Everybody loves it. The fact that it is unique, they haven't experienced this anywhere else because it's still a relatively new modality. That is very good. I mean, it's patients like that. They love being treated with state-of-the-art stuff. And I play that up. I tell them, I'm the only one in the area that has one and stuff like that. So the response is very favorable. And in many instances, they feel the decrease in pain that kind of carries over to the next session. And they attribute it to the machine. They start asking for the machine. I want that thing. So it's all very positive.
Yeah, I hear that a lot too, including from myself. I want that thing.
That's right.
Dr. Wijting, I'm so sorry. There are so many more questions coming through and that I have, but we've run out of time. This concludes our hour 2 presentation on high energy inductive therapy. Thank you so much again, Dr. Wijting.
You're very welcome.
That also concludes the CE portion of this webinar. However, Gerald Gable would like to come on again one last time, and he's the VP of Sales at Zimmer MedizinSystems. He'll take just a couple of moments to talk to you about the M-Field Pro HEIT system. Hi, Gerald.
Hey again, it's me again. And I promise I'll make it even shorter this time. But just to speak a little bit on the business side of things, of course, here. Let me share my screen again. I have some slides prepared. By the way, I get asked also a lot, are there codes for reimbursement? There are codes for reimbursement. One of them would be neuromuscular reeducation, for example. But our suggestion always is to go down the cash route because it's more uncomplicated and you get probably paid higher than if you would go with the reimbursement code. And for that, I've brought real life examples of 2 clinics that I have been working with. The first one is an example here from Florida, chiropractic clinic in Florida. 1 DC in the clinic, 2 CAs, a receptionist, and 1 M-Field Pro unit. And the workflow in that clinic is the DC recommends the HEIT treatment for an indication during the consultation and the first adjustment. And then the cost for the HEIT treatment is $98 for a single HEIT session, and the patient will be charged as many sessions as they need until the issue gets resolved. And this clinic specifically mentions to me that they don't sell any packages. This is a little bit out of the norm. Most will sell a package, but in this case, it isn't. And they have approximately 10 patients per day on the M-Field, which is high. I have been in that clinic and they are busy. The machine is practically working every 30 minutes with a new patient. So they make full usage out of that thing, which is good. And I should also say, and Yorick mentioned that before, it's mainly unattended. It's 90% of the time you have it in the arm, unattended, and you can do other stuff while the machine is working because it doesn't do any harm. The patient can move it away whenever they want or feel uncomfortable, which normally doesn't happen. Most patients fall asleep because they like it so much and feel very, very comfortable. So how does that look like if we put that in our return on investment sheet that we have? So $39,000 is the price of the device. They charge $98 per session and they have 50 a week. So you will see after the first year, they already made $209,000. But the bigger achievement was when the doctor called me after the 3rd month of having the device in his clinic and saying, hey, the device is paid off. Now everything goes into my pocket, which is great. And also, even though we offer loans or finance to own, in this case, he wanted to put everything on the credit card because he gets points. So that's what we offer. We can do that. You can pay with credit card and get the points and no credit card fee from our side. There's the second example, a clinic in Texas, South Texas, again, 1 DC, 2 CAs, and in the meantime, they have 2 M-Field units. They started out with 1 M-Field unit. After the short period of time of 8 months, they went and get a second unit because the doctor told me it's booked out all the time. Same situation as the doctor in Florida and same situation as Yorick described before. Everybody wants and demands to have that unit that comes in, and also a really good effect that they tell everybody of their friends and say, hey, you need to go to Dr. XYZ. He has that magnetic unit that will help you, right? So again, the doctor recommends it. They do a 10-minute free trial with the device. And then afterwards, the doctor doesn't speak to them. The CA comes and checks in if they wanted to sign up for a package of 5 or a package of 10, which in this case would be the package of 5, $345. The package of 10 would be $650. And during my time there, 90% of the patients that I saw there signed up for one of the programs.
Gerald, I'm so sorry. I need to end the presentation.
Yes.
I apologize.
problem.
We have doctors that have patients waiting in their clinics. So
All good.
again, thank you for your expertise. Thank you for Zimmer MedizinSystems for sponsoring this today. Thank you for Dr. Wijting, Dr. McAlister. Attendees, we appreciate you. Thank you very much today.
Yes.
Bye-bye.
Thank you, everybody, for having us.
Bye-bye.
Bye.
And if anyone would like more information about the M-Field Pro or N-Pulse Pro systems, please visit Zimmer MedizinSystems website at www.zimmerusa.com. If you'd like to speak with Dr. McAlister, Dr. Wijting, or Gerald Gable directly, please send an email to info@zimmerusa.com and they can forward your inquiries and connect you. That wraps up today's session. Thank you for spending time with us and for being part of the discussion.